This is just a little bit for the juniors who regularly see X-rays but cannot make out how to see the grade of the adenoids. So it is a very simple rule that we should follow. What I usually explain to the parents is, so this is the upper teeth, this is the nose of the child, and the main thing we have to focus on is the airway. So as we breathe, the air goes through the nose, then to the back of the throat and goes below, and this is the airway which goes into the lungs. The easiest way to spot the adenoid is to see right at the back of the nose. Now in this case, as we trace the airway, we can see that at this point there is complete obliteration of the airway. So we can assume that this is the grade 4 adenoids. Yes, clinically it is very important to ask the parents how the child is. Is she snoring every day at night? Does the child have mouth breathing? But in case few children don't allow endoscopy in the OPD, the simplest way to detect the adenoid hypertrophy is on an X-ray. And this is the simplest way to spot it. Even if the X-ray is not well done, sometimes there is overlapping. The simplest way is to trace the airway and check where the airway is getting narrowed. Mostly 90% of the times that is where the adenoid hypertrophy will be seen. So this is just for the benefit of the patients who want to know how the surgery is done. The surgery nowadays is done endoscopically, that is we visualize the adenoids through the nose via endoscope, and the whole picture comes on this monitor. So this is the Stowe's 4K monitor, the latest technology available here and throughout the world for this surgery. The instrument used to remove the adenoid and tonsil is called a coblator. Now the coblator works on a plasma medium where saline is used to reduce the thermal damage, and the saline media helps remove the whole of the adenoids in a clean fashion without a lot of blood loss. This is the coblator machine that we have here. So this is the Smith & Nephew ArthroCare coblator machine. This comes with an attachment of a wand. The wand is the one which is used to remove the adenoid tissue. This is the coblation wand what I was speaking about. So this is connected to our machine. These wands have these leads and it has a saline supply. So as the saline comes in, the leads will generate the power, and through these leads and the shaft, all of the adenoid tissue is taken away. So the advantage of doing the procedure endoscopically is that though the entire middle part of the adenoid has been removed, these corners are what is missed in the conventional technique. So now with the endoscope, we can see these tissues in the corners, and from every nook and cranny, the adenoid tissue is removed, which gives the complete benefit to the patient and prevents any regrowth. This is the tonsil cavity after the tonsillectomy. As you can see, the capsule is preserved, which will prevent a lot of post-operative pain. Here, a little bit of the capsule has been come with the tonsil, but that's okay. Majority we have preserved it. This is on the right side. Similarly, on the left side, you can see that the entire capsule is preserved and there is hardly any bleeding after the tonsil has been removed. So, just a small tip for the beginners or even the surgeons who are regularly doing the surgery. I always prefer to give an infiltration once the tonsillectomy is done. So post-operatively, the child will be a little more cooperative. So there is a mixture of 0.25 bupivacaine, 2.5 ml and 2.5 ml of 2% lox with adrenaline. We just inject it into the tonsillar fossa, that is the lower pole, the upper pole and little bit in the fossa. Be careful not to touch the paratonsillar vein.